I'm going to start. So my name is Dayna Ferguson. I'm one of the conserves at Rahima ED. So the talk that I'm going to be discussing today is paracetamol and salicylate toxicity, which is quite an important and interesting topic, especially in the ED setting. So if anybody has any questions, please stop me and feel free to ask questions. Can everybody see my slides and hear me properly?
Yes, we can.
Yes. Okay, so just to introduce the topic, paracetamol and salicylates are the most commonly used non-prescription analgesia, and this is because they're widely available as over-the-counter medications. But because of this, they're also commonly used in intentional overdoses. So both paracetamol and salicylates are safe in therapeutic doses, but in toxic doses, paracetamol causes hepatic necrosis, and salicylates cause toxicity via multiple cellular and systemic mechanisms, which we'll discuss a little bit later. So first to discuss paracetamol toxicity. So a one-year study conducted in 2018 at Tygerberg Poison Information Center, they looked at consultations over a one-year period, found that 61% of adult poisoning cases were due to deliberate overdose of medication. And paracetamol was the most frequently used drug, and this is probably because it's so accessible over the counter. This was in adults. In children, it's often unintentional overdoses. So you have exploratory mechanisms. So, for example, where children ingest unsecured medication that are lying around at home. And another common one is concurrent dosing. So the use of multiple agents containing paracetamol. So, for example, moms at home will give Calpol and then will go to the local clinic and get normal paracetamol, and they'll give both of those together. You do also have iatrogenic overdoses in children, which is quite an important thing to talk about, especially in our setting, because it's happened to me before, where an incorrect dose of, for example, IV medication is given, so pifalgin. So you ask for 100 milligrams of pifalgin, but it's given as 100 mils instead of 100 milligrams. So it's also just something important to remember when writing up prescriptions, just to be clear about your dosing. So types of overdoses with paracetamol, you've got your acute overdoses. So that's where excess amounts are ingested over less than an hour, and these are usually intentional overdoses. Your staggered overdoses are ingested over greater than an hour. These are also usually intentional. And then you've got your therapeutic overdose. So this is excess amounts ingested with the intent to treat pain or fever without the intent of self-harm. And this is often seen in our kiddies. At Rahima, if kiddies present with an overdose, this is usually the presentation. So just to discuss the pharmacology of paracetamol, therapeutic dosing in adults is 325 to 1,000 milligrams per dose with a maximum of 4 grams per day. And in children, it's 10 to 15 milligrams per kilogram per dose with a maximum of 80 to 90 milligrams per kilogram per day, depending on which literature you look at. But just for safety, I went with 18. Half-life is 2 to 4 hours. And interestingly, most of the absorption occurs in the duodenum, and serum concentrations peak 1.5 to 2 hours after oral ingestion. Obviously, your pharmacology is different with your IV agents, but I'm not going to go into detail about that. So your metabolism of paracetamol, 90% of it undergoes glucuronidation in the liver, and this produces a water-soluble conjugate that's excreted in the urine. So this is not a toxic metabolite. The remaining 10% of this paracetamol is oxidized by cytochrome P450, and this is turned into a toxic metabolite, which is your N-acetyl P-benzoquinoline, or NAPQ, NAPQI for short. And in therapeutic doses, NAPQI binds to glutathione, which is a protein in the body, and this produces a non-toxic metabolite that gets excreted in the urine. But in toxic doses, these pathways become saturated, and excess NAPQI binds to hepatocytes and causes mitochondrial injury and hepatic necrosis. And in your very severe cases, this causes acute liver failure and can even cause death. So just quickly touch on factors affecting toxicity. Obviously, the most important one is excessive intake of paracetamol, and this is the most important factor. But other factors to consider is inducers of cytochrome P450 activities, and important medications in our setting is phenytoin, phenobarb, rifampicin, and any other medications that induce cytochrome activity, and thus may increase the risk of liver injury following an overdose. Other important factors is glutathione deficiency, your nutrition and body weight. So low levels of glutathione increases the risk of liver injury following an overdose. And this is seen in your malnourishment, your eating disorders, and your alcohol use disorders. Age, in children less than 5 years, they may be at less risk for toxicity, and this is due to regeneration and supply of glutathione stores in conjugation with sulfate. But important to know that adult patterns of metabolism occur from the ages of 10 to 12. I'm not sure if anybody knows anything about alcohol ingestion and their effects on paracetamol metabolism or toxicity. Okay. Interestingly, alcohol ingestion, acute and chronic, do not appear to directly affect the risk for hepatotoxicity when paracetamol is used in therapeutic doses. And acute alcohol intoxication may even be protective, as cytochrome P450 becomes saturated, and this prevents the formation of the toxic metabolite NAPQI, which I thought that was quite interesting. So your clinical presentation depends on the type of overdose and the time from overdose to presentation at the ED. So your typical early features, so patients presenting less than 12 hours, they can be potentially asymptomatic, may present with nausea, vomiting, lethargy, and mild to moderate abdominal pain. Your typical late features include moderate to severe abdominal pain, a metabolic acidosis, jaundice, acute kidney injury, hepatic encephalopathy, coma, or coagulopathy secondary to hepatic damage. It's also important to note that patients with a very high dose toxicity, so typically more than 350 milligrams per kilogram or greater than 30 grams, can develop an altered mental status and a metabolic acidosis early, so within 8 hours of ingestion. So that's why it's important to just take the history and see the type of overdose and how much was ingested. So this is just a very nice summary that I found on UpToDate that goes through the hours after ingestion and the clinical presentation. This divides the stages into stages 1 to 4, and then obviously the hours after ingestion. So your early presentation, as we've discussed in stage 1, can be asymptomatic or can have those very non-specific symptoms. Stage 2, 24 to 72 hours, is when you start to have your metabolic derangements and your elevations of your LFTs and your PTTs and all of that. And then stage 3 to 4 are your later stages, stage 4 being your recovery phase. So investigations specific to paracetamol toxicity. Patients requiring hospital assessment are those that are symptomatic and those that have intentional paracetamol overdoses. And this is regardless of the dose because it's an intentional paracetamol overdose. If you have ingested a high dose of 75 milligrams per kilogram over less than an hour, and all staggered paracetamol overdoses. So relevant investigations, the most important one is your serum paracetamol level. This is done as soon as possible, but generally greater than 4 hours after your ingestion. You also do your baseline electrolytes, LFTs, iron on PTT. So once you have your paracetamol levels, you can use the Rumac-Matthew normogram. And this can only be used if the time of ingestion is greater than 4 hours. So it's unreliable if the history of ingestion is uncertain, if the ingestion occurred greater than 24 hours prior to presentation, repeated supratherapeutic ingestions, or iatrogenic IV overdoses. So this is the revised Rumac-Matthew normogram. It's a little bit different to the one that we have in our protocol book, but they've revised this nomogram and they've included like a safe line. so that you can see you've got your high-risk line, your treatment line. So it's basically exactly the same thing, but it's just a revised nomogram. So I've included it in the slides so we can just have a look at that in our own time. So management of paracetamol overdose I've divided into hours after presentation. So in your acute overdoses where they ingest them in less than 1 hour, if they present within 8 hours of ingestion, you obviously do your ABCDE first, but if they're presenting early, you can do GI contamination with activated charcoal. I'll discuss activated charcoal a little bit later. And then you wait 4 hours from your last ingestion, and then you take your bloods and you start ACC if your paracetamol level is above the treatment line or if there's evidence of liver injury. So this is usually represented by an increased ALT. If they're presenting 8 to 24 hours after ingestion, you take bloods, and then if it's greater than 150 milligrams per kilogram ingested or an unknown amount, or they are symptomatic, you start ACC while you await the results. If it's less than that, you wait for the results and start ACC if the paracetamol level is above the treatment line or there's evidence of liver injury. And greater than 24 hours after ingestion, it's the same thing. You take blood immediately, and if it's greater than 150 milligrams per kilogram ingested paracetamol, or they're symptomatic, you start ACC, and if it's less than that, then you wait for the results, or you start it if the ALT is raised, you have INR derangements, or any serum paracetamol level is detected. So just to touch a little bit on activated charcoal, gastric lavage and emptying is not recommended over normal activated charcoal. And the dosing of in kiddies is 10 to 25 grams if they're up to 1 year of age. If they're 1 to 12 years of age, 25 to 50 grams. And in adolescents and adults, it's 25 to 100 grams. In your staggered overdoses, so your patients ingesting paracetamol in over greater than an hour's period, you start ACC treatment immediately. Then you wait 4 hours from the last ingestion and take bloods. And you only consider discontinuing with ACC if there's a low risk of hepatotoxicity. So your paracetamol concentration is less than 10 milligrams per liter. You have a normal ALT, INR is less than 1.3, or they're asymptomatic. If they have therapeutic excess, so greater than 24 hours after ingestion, if they're symptomatic, you start ACC, but this is quite a complicated patient to manage. So it depends on the patient's weight and the quantity consumed in the last 24 hours. And it's advised to just call poison center or a toxin specialist if you have patients that present like this. Okay, so just to very briefly touch on activated charcoal. It can be given if the presentation is within 4 hours. You can prolong this up to 8 hours depending on how the patient presents. Contraindications to activated charcoal is GI obstruction. If you have an altered GCS and a need for airway protection, you're not going to give anything orally. And it's also just to remember that it's ineffective with certain toxins such as ethanol, methanol, petrol and paraffin, your lithium, your bleach, and your other caustic alkalis. So we've really quickly discussed how to give it. So another thing to mention is you give it as a slurry. So if you're less than 6 years of age, you can mix it in 50 to 100 ml of water. Or as Dr. Bailey Stanton suggested previously, you can mix it with like a cool drink or something just to make it a little bit more appetizing. Put it in a Coke bottle, for example. And as we've mentioned, gastric lavage and emptying is not recommended as it's actually been found to be less effective than oral charcoal. And just the picture that I've inserted here is a picture that we have in our toxicology box. So this is the activated charcoal that's available in our cupboard. Okay, so acetylcysteine or ACC, just to discuss how you would give that. There are multiple regimens that are available, but all regimens agree that at least 300 milligrams per kilogram of ACC should be administered orally or intravenously in the first 20 to 24 hours of treatment. So the 20-hour regimen is what is discussed in our Department of Health guidelines, and that's 200 milligrams per kilogram and 7 moles per kilogram of 5% dextrose over 4 hours, and then 100 in 14 moles per kilogram of 5% dextrose over 16 hours. The standard 21 regimen is what's discussed in most literature, and it's also the protocol that was used at Becky Hospital. So that's just 150 milligrams per kilogram over 1 hour, then 50 over 4 hours, and then 100 over 16 hours. And for this regimen, dosing in children is exactly the same, but you just have dilutional changes. So, for example, you'll put it in 7 moles per kilogram of diluent for 150. And in pregnant patients, which is important in our setting, you calculate the toxic doses of paracetamol as well as your ACC dosing according to patients' pre-pregnancy weight. So you don't take their current weight, you take their pre-pregnancy weight. Um, and then just to discuss the SNAP protocol, which is the Scottish and Newcastle acetylcysteine protocol. So it's a new protocol that's recently come about. It's a 12-hour protocol, so it's much shorter. Advantages of this protocol is that there are less side effects. There's a shorter hospital stay, and it's quite simple to use. So you have a first bag and a second bag system. So your first bag is 100 milligrams per kilogram of ACC over 2 hours, and then your second bag is 200 milligrams over 10 hours. And I know that this is the protocol that is being used at Helen Joseph at the moment. And very important to just note that there's no difference in liver injury or liver synthetic dysfunction between regimens. It's just obviously for ease and what your center uses. So your adverse effects and your allergies for acetylcysteine, your common ones are your nausea, flushing, your rash, angioedema, tachycardia, and bronchospasm. And your rare ones are your hypertension and collapse. But it's not a contraindication to treatment. And if there is a history of sensitivity, then you can consider giving an antihistamine prior to that. Anaphylactic reactions are usually dose related, so most commonly occur during the first dosing of acetylcysteine. So, for example, in your first bag infusion, if you're using SNAP protocol. Your stopping criteria for ACC is if your serum paracetamol concentration is less than 10 micrograms per milliliter, you have an INR of less than 10, you have your normal ALT and AST, or they're at your baseline. So, for example, if someone has chronic liver disease, it's at their baseline, then there's no clinical signs of toxicity. And if these criteria are not met, then you continue your ACC at a rate of 6.25 milligrams per kilogram per hour, and you reevaluate 12-hourly. And then just these pictures at the bottom, these are your IV preparations of acetylcysteine. They come in different strengths and doses, so it's important to just check that before you administer it. And then you do also have your other preparations that you can get over the counter. So this Voltex ACC is what we have in our tox box, which we'll touch on a little bit later. So this is just quite a nice summary table for the SNAP protocol dosing. So it goes by weight, and then it also gives you your first infusion and your second infusion. I found this to be quite useful. So instead of having to remember 100 milligrams per kilogram and whatever, it gives you your infusion rates and your dosing. So this will just be quite nice to look at if you need to see it in future. So these two tables. So to discuss complications and prevention, complications of your paracetamol toxicity can be divided into your common and your rare ones. So your common one is your nausea, vomiting, and abdominal pain. And your rare complications is acute liver failure, renal impairment, and death. And here you can use the King's College criteria for acute liver failure to assess whether or not a patient needs a transplant. But I'm not going to go into detail about that. And then just for prevention, to prevent paracetamol overdose, it's important to counsel patients and to follow weight-based dosing and maximum dosages. So important to tell parents to avoid concurrent dosing with multiple paracetamol agents. So if they're giving Calpol at home and you're prescribing paracetamol, just to tell them not to give the Calpol because it contains the same medication. So avoid supertherapeutic dosing in children, and also just to have caution with rectal suppositories as it has a different pharmacology. And obviously avoid adult paracetamol preparations in children. So this is also just quite a nice summary slide for paracetamol overdose management, And this is using the SNAP protocol. So I'm also not going to go through this, but it's nice if you want to just have a broad overview of how to manage paracetamol toxicity. Okay, before we move on to salicylate toxicity, are there any questions? Okay, if there are any questions, we can just address them at the end. So salicylates are a group of non-steroidal anti-inflammatories that have a dual action. So they act as an antiplatelet at lower doses and an analgesic at higher doses. They come in multiple preparations. So your aspirin is your most common. In our setting, methyl salicylate or rub is also very common. You have your bismuth subsalicylate or your Pepto-Bismol, your salicylic acids, and your magnesium salicylates. It's quite difficult to find South African data on salicylate toxicity, but the 2021 annual report of the American Association of Poison Control Centers, their data system, the NPDS, showed that 20,000 reports of salicylate poisoning were reported, 4,000 of which were children, and there were 50 to 70 fatalities. So it's quite an important thing to recognize and keep in the back of your mind when you see a patient presenting with toxicity. So your types of salicylate overdoses, you have your intentional and your accidental. Your intentional is your intent to cause self-harm or to suicide attempt. And your accidental is a more common presentation, and this is due to widespread use. And it often occurs to non-prescription aspirin-containing products that leads to inadvertent ingestion. So for example, in your kiddies, mommies will give medications that they don't know contains aspirin, and then this can lead to salicylate toxicity. Pharmacology of salicylates, your toxic dosing, if they present with less than 150 milligrams per kilogram, they may be asymptomatic. 100 to 300 milligrams per kilogram is your mild to moderate toxicity. 300 to 500 milligrams per kilogram is your severe toxicity, and greater than 500 is potentially lethal. Half-life is 3 to 6 hours, and your absorption occurs in the jejunum, stomach, duodenum, and the skin. So this is important with your rubs. And your serum concentrations peak after 1 hour of oral ingestion. This is obviously different depending on the different mechanisms. So skin is different to oral. So aspirin metabolism is quite complicated. So just to briefly touch on it, it's rapidly hydrolyzed in the plasma to salicylic acid. And then salicylic acid is conjugated in the liver to form salicyluric acid, which is less toxic, and other metabolites. So typically a 10%, typically 10% of an administered dose is excreted in the urine as salicylic acid, 75% is salicyluric acid, and 15% is your other metabolites. And renal excretion of the unchanged drug depends on urine pH. So as you increase your urine pH, the renal excretion of salicylic acid increases. And this will become important later on when we talk about management. So as we mentioned much earlier, mechanisms of toxicity occur via multiple cellular and systemic pathways. And this is just because your pathways become saturated. So, for example, it interferes with cellular metabolism, which leads to metabolic acidosis, hypothermia, and fluid losses. Depletion of your glycogen stores leads to hypoglycemia and neuroglycopenia. It also causes a catabolic state, which leads to keto acids building up. In your medulla, it directly stimulates chemoreceptors, causing nausea and vomiting. And it also activates your respiratory center, which causes tachypnea, hyperventilation, your respiratory alkalosis, increased renal elimination of bicarbonate, increased insensible fluid losses. Your insensible fluid losses comes from your tachypnea and your hypothermia. You do also have direct irritation of the gastric mucosa, which can cause ulcers and hemorrhage, and it also directly affects the cochlear ear cells, which causes tinnitus. And in your very severe cases, it directly inactivates the CNS system and causes cardiorespiratory arrest. So your clinical presentation of your salicylates depends on the severity of your poisoning. If you have mild toxicity, you present with nausea, vomiting, epigastric pain, tinnitus, dizziness and lethargy. Moderate toxicity presents with sweating, fever, and dyspnea, and severe toxicity presents with your confusions, convulsions, and coma. But your typical findings in your moderate to severe toxicity is your warm peripheries, your bounding pulses, tachypnea, hyperventilation, arrhythmias, and they can also present with acute pulmonary edema. So this is also just a summary slide, a nice table on the clinical presentation of salicylate. So it divides it up into mild, moderate, and severe toxicity. It also mentions your serum salicylate concentrations, which we'll talk about a little bit later. So investigations in salicylate toxicity, your most important investigations are your bedside investigations. So you assess clinical status. So your tachycardias and tachypneas are quite common. Do ECGs because they can present with arrhythmias and QRS or QT interval prolongation. You obviously want to check your glucose because they can present with hypo or hyperglycemia as well as a ketoacidosis. And you need to do an arterial blood gas. So initially, your hyperventilation causes a respiratory alkalosis, which then progresses to a metabolic acidosis with a partial respiratory compensation. So your laboratory investigations, you can take plasma salicylate levels, which are ideally taken 2 hours after ingestion. And according to guidelines, they say repeat 2 hourlies until you reach your peak levels. But in our setting, this isn't really realistic. It takes quite a long time for salicylate levels to come out. So it's better to just go clinically than to rely on salicylate levels. For example, I recently had a patient who we did salicylate levels on, and it took 2 weeks for the results to come back. And by that time, the child had already demised. So it's not really useful to do repeats or even just baseline salicylate levels and wait for a decision to act on that. You also want to do your plasma paracetamol levels because mixed overdoses are quite common. And you do your baseline blood, your FBC, UNE, LFTs, INR, and PTT. And important that you can consider imaging, so CT brain, if they have an altered mental status or there's a suspicion of intracranial pathology. So I've included the slide mainly for interest. So again, as I mentioned, it's not necessarily relevant in our setting because we don't often have access to serum salicylate levels quite quickly. But it's the done nomogram. So historically, the severity of the risk of a single acute salicylate ingestion was interpreted using this nomogram. But now dose, patient age, renal function, hydration status, they're all factors that determine the degree of salicylate toxicity. So yeah, this is purely just for interest. So management of salicylate toxicity, it's important to note that there's no antidote for salicylate toxicity. So treatment is purely supportive. So we'll just discuss the initial and ongoing management here. Obviously, A, B, C, D, E first, with particular attention paid to airway management, as these patients risk losing their airway quite quickly. So in your initial management, you can give activated charcoal if presentation occurs within 1 hour of ingestion or if it's greater than 125 milligrams per kilogram. But as we discussed earlier, you avoid if there's an altered GCS or your airway is compromised. Your IV fluid resuscitation, if necessary, so you assess the patient's clinical status first. Typically, you use 0.9% sodium chloride, but you can use a 5% dextrose solution if they're hypoglycemic. Potassium replacement, you aim to keep the plasma level at 4 to 4.5 millimoles. So again, these initial managements are very much guided by your clinical presentation. So if the patient's potassium is normal, you're not going to replace it. And you give sodium bicarb. So it's an 8.4% IV solution in 1 mol per kilogram boluses. And this is to decrease the transfer of salicylates into the central nervous system and to increase the urinary excretion of salicylates by causing urinary alkalization. So as we discussed earlier, as you alkalize the urine, it increases the salicylic acid excretion. So you aim for a urine pH of 7.5 to 8.5. Your ongoing management, you have your cooling measures if your patient is hypothermic, so you want to keep them normothermic. Hemodialysis can be considered in your renal failures or severe metabolic acidosis if they're having ongoing seizures, if you have a salicylate greater than 900 milligrams per liter or coma. But in our setting, in the public sector, this is quite limited. Your benzodiazepines for your seizure control, CPAP or endotracheal intubation to manage your airway, and obviously psychological support. So your complications of salicylate toxicity is acute respiratory distress syndrome. And this occurs because you have bilateral pulmonary edema and hypoxia that's not explained by cardiac failure. And the management of this is also supportive. So it's intubation and ventilation with an increased PEEP to prevent alveolar collapse. You can also have seizures, which is managed by benzodiazepines, but important to remember you may need intubation and ventilation to manage these patients. You can also have a drug-induced hepatitis, which has a low incidence and generally resolves as your toxicity resolves. And important to note, you can have cardiac arrest, and this occurs from a prolonged QT interval, which leads to polymorphic VTAC or VFib. And you manage this by ACLS principles, which I'm not going to go into detail about here. So just to very briefly touch on Reye syndrome, just because it's quite an important thing to remember with our kiddies. It's a post-infectious triad that consists of encephalopathy, fatty liver degeneration, transaminase elevation, and it's a rapidly progressive encephalopathy with hepatic dysfunction. It's a multi-stage illness and it affects all of the organs, but primarily the brain and the liver. The reason that it's important to discuss here is because aspirin use increases the risk for Reye syndrome 35-fold. So, for example, you'll have a kiddie who has a prodromal febrile illness. Mommy gives aspirin at home. They have resolution of symptoms, and then 5 to 7 days they present with abrupt neurological impairment, vomiting. It's just to keep in the back of your mind when you see this. It's quite a difficult syndrome to diagnose. Signs and symptoms are quite general. So you have your persistent or recurrent vomiting, your listlessness, personality changes, your confusion, delirium, convulsions, and loss of consciousness. So yeah, it is quite a complicated topic, but just something to keep in the back of your mind when you see these kiddies. So just to touch on our toxicology box that we have in our cupboard, it's in our main cupboard in the ED. And it's labeled toxicology box. You can see I've shown a picture of where it is. It's on the left-hand side of the cupboard. And this toxicology box has got all of our little goodies in it that we might not have access to generally. So you've got your Voltex in here, your activated charcoal. You've got a whole lot of other stuff, naloxone, generally stuff that's not easily accessible in our hospital. Some of the stuff may be expired, but you know, in a situation where you need it, does it really matter? So important to maybe go and have a look at our toxicology box and just familiarize yourselves with what we have in it. So yeah, that is all. If anybody has any questions.